So today I'm going to start discussion about the OPD cases or the ER cases that I have encountered and diagnosed. So diabetic patient came to ER with vomiting. Diabetic patient with vomiting. Pulse is 40. So one can think of a patient is diabetic, so that is a high risk factor for coronary artery disease or ischemic heart disease, and the patient is vomiting while looking at the pulse of 40. One can think that the patient is having severe bradycardia. Now if the patient is having vomiting and pulse of 40 and the patient is diabetic, you have to exclude number one thing, that is acute coronary syndrome. So you have to exclude acute coronary syndrome. So the ECG of this patient came out to be left bundle branch block, and the cardiac enzyme was significantly raised, and the patient was referred to the cardiac ER and managed accordingly. So this was the case, that if a diabetic patient comes to you with vomiting can be the sign of ischemic heart disease. No chest pain. Why? Because in diabetes what happens, there is neuropathy, as there is no sensation of pain from the periphery, such as the foot or hand. There is no pain sensation from the chest, so there is really no pain. So another scenario is diabetic patient with vomiting and abdominal pain. Diabetic patient with vomiting, abdominal pain, but the pulse was this time was 110. So you can say directly from the pulse that severe bradycardia, that is actually cardiogenic shock. But this is not hard and fast rule. You have to look at the ECG. Now this was the patient, and patient was as having dyspnea with clear chest. Now if the diabetic patient is vomiting, abdominal pain, pulse is 110, dyspnea with clear chest, you should think of metabolic abnormality. So what are the two metabolic abnormalities? What are the two metabolic abnormalities in diabetic patient with vomiting and drowsiness? Number one is the DKA, and number second is the honk, hyperosmolar non-ketotic coma. So if a diabetic patient comes to you with vomiting, first thing is exclude ischemic heart disease, acute coronary syndrome. Next step is exclude DKA and honk. Now there was a third patient that I received. Patient was actually having vertigo. Again, this patient was diabetic. Patient was having vertigo, and he was having tinnitus. Now the patient coming to the ER, they will tell you whether there is a spinning sensation, or there is actually a dizziness. These two are different things, and management of both are different. Well, the spinning sensation mean usually the problem is in the inner ear, while the dizziness mean there is blackouts. The problem is usually cardiovascular system. Well, this is usually the inner ear or CNS system. System. So patient come with vertigo and tinnitus, and this was actually has a second episode. First one was 6 months back. No chest pain, BP pulse normal, ECG was okay. So this was actually a case of Meniere's disease. case of mania disease. So these were some cases that I encountered in the ER.